Fentanyl is increasingly becoming a hot topic in today's society. We see an increasing number of overdoses from the drug itself, with heroin being mixed into fentanyl create an even better high, often with deadly consequences. However, there's a lot of myth surrounding fentanyl itself. We've all seen YouTube videos and reels about law enforcement officers who quote unquote overdose on fentanyl, suddenly becoming incoherent, pass out, have seizures, all from incidental exposure. So today's episode of the JAFERD cast, we're going to dive into the world of fentanyl, opiate use and overuse, and dispel some of the myths around fentanyl and heroin use in general. Is fentanyl a bad drug? The answer is it depends. If it's being used in a medical context, no. It is actually a very potent pain reliever that we often give in a hospital setting under, of course, very controlled circumstances. To help dispel a lot of these myths and rumors, I'm going to be joined by Dr. Christopher Counts, a board-certified EM physician and toxicologist, where we're going to go over what fentanyl is, what an overdose looks like, is what you're seeing on the internet even real, and to top it all off, we're going to do it and hopefully not have you fall asleep in the meantime. This is the JAFERD cast. Let's get going. All right. Hello, Dr. Christopher Counts. Welcome to the show.
Thank you so much for having me.
Absolutely. All right. So, you are an ER physician, just like moi, but you're more qualified. You are also a fellowship trained toxicologist. Is that correct?
Correct.
So tell me about that. So first of all, emergency medicine specialty, 3 to 4 year residency program, but then fellowship. What is involved with this fellowship here?
So my fellowship was 2 years long. All toxicology fellowships are. And there's a couple different components to it. So the pace of it slows down a little bit from what we're used to in the ER. We have a lot fewer patients, a lot more time to think about them.
Time to think, what is this shit?
It's you have to shift gears a lot when you're going from the ER to the poison center. But I was associated with the New Jersey Poison Center, and we took calls from all across the state, healthcare facilities, as well as people calling in with potential toxic and poisonous exposures. And then we also had a small inpatient service at a hospital in Newark as well.
I remember when I was in medical school, I rotated at Lehigh Valley Hospital, and I actually did a 1 month toxicology rotation with them. It was pretty interesting. It was very, very academic. Like there was a lot of didactics, but we did round on patients that we were consulted on for toxicology, both pediatric and adult. And I remember it was a salicylate, an aspirin overdose that was in the ICU, who unfortunately didn't survive. But I remember our attending got the call like late at night, like 2 a.m, and it was like, hey, this patient's going to the ICU, aspirin overdose, suicide attempt. And, we're doing these things, but he's breathing pretty quick and we're actually going to put him on a ventilator. And I remember my attending was like, no, do not do that. It was a whole thing where he went into, but I was surprised that actually you don't want to put these patients on a ventilator.
Yeah, aspirin and salicylates in general are one of those. There's many, but one of the overdoses that scares me a lot. And I think even the most seasoned toxicologists get very nervous about those.
Yeah. And again, we're not going to talk about this. I think we should do it in like one episode, at least on certain overdose, like common overdoses too, especially in the wake of all this Tylenol bullshit going on. But I know the main point about your fellowship is basically just like researching a lot of these, not just poisons, but you're also looking at common medications. I mean, obviously Tylenol, aspirin, and all that's a common medication, but how to treat this, the ways effectively to treat this, things like that. And you're not just talking to patients, you're also talking to us. Like I'm calling into the Poison Control Center. So you're talking to other providers as well.
Exactly. We interact with providers from, the entire healthcare spectrum. 1 minute you might be on the phone with someone from like a pediatric ICU and talking to, an ER doctor. It definitely gives you a chance to improve your communication skills and how to communicate recommendations over the phone.
So do you get a lot of calls from patients about opiate overdoses, things like that? Or is that mostly just handled by 911?
So 911 will handle the majority of the calls for an acute overdose requiring an ambulance to go out there and administer naloxone. We do get a variety of calls related to opioid use in general, in unfortunate cases when a young child, for example, might be exposed to an opioid and ends up in the ICU. The team will sometimes want to do some testing to find out what opioid it was or what other agents they might might have been exposed to. So there's lots of different kind of opioid related issues that come up.
And I have some questions on that. So you talk about, testing for an opiate. Now, we're not CSI. I think a lot of patients come into the ER. They think that, oh, my child or I, got something in my drink or they took a pill or they have something and I don't know what it is. Can you test it? And the answer is not
No.
really. The answer is no. CSI was you get the chemical, you take the blood, you do like PCR molecular analysis, and you're like, oh, yeah, this is the dimerization of, oxycodone. It's a very potent date rape drug. Like, no, sorry, I don't know what your child, your teenager, or college student, took. I don't know what you took. And I think I feel like the teaching moment I have a lot of these patients is we treat toxidromes. And I don't know if you agree or disagree on that one. We see a patient who presents clinically a certain way and we treat the clinical presentation.
Yes. No, a lot of toxicology is about learning how to recognize those toxidromes and then how to also get other people within the healthcare system to recognize them in their patient. For
What are
example,
the Yeah, go ahead.
yeah, so if there's, say, someone took an overdose of an SSRI, which is a common antidepressant, it can present with some changes in mental status, but lots of things cause changes in mental status. And so helping, guide folks through the differential diagnosis, both toxicologically and the non-toxicologic diagnosis differential is very important.
Yeah, and you talk about someone who comes in, acting, let's say, batshit crazy, right?
Well,
Like, you see people like in the street, for example, acting a certain way, and you think, oh, they're crazy. And they might be. There's a very good chance it could just be absolutely crazy off their psych medication, whatever. But then police get involved, 911 gets involved, and you realize that, oh, this patient is suffering from a medical condition. Somebody comes in, SSRI poisoning, let's say, they're altered. What does that look like?
yeah, so it will depend a little bit on how much they took, when they took it. In the most severe forms, patients can be sedated. Sometimes they can even seize. And then the kind of constellation of serotonin toxicity are things like GI symptoms, so a lot of vomiting and diarrhea. I think, we as healthcare providers often forget that the most serotonin we have in our body is actually kind of in the gut. So if you
Mm.
have a serotonin excess, you'll have a lot of GI symptoms.
Yeah, and it's interesting because one of the most common nausea medications, Zofran or ondansetron, targets those types of receptors,
Hmm.
especially in the gut too. So involved with a lot of stuff. So people are probably listening to this and going, "Okay, when are they getting to the opiates?" And the reason why I'm talking about the toxidrome, and toxidrome meaning that how is a patient presenting to you? Are they sweaty? Are they dry? Are they confused? Are they vomiting? Do they have constipation? Like all these clinical symptoms fit into a giant picture. And so now we talk about opiates, and these patients too have a clear clinical picture that people are very familiar with. They're rolling in here and they're not breathing. that's
Yep.
that's the main thing. It's, oh my God, they're not breathing. And, usually they come around with Narcan, Naloxone. Other times they don't. They're getting it on ventilator, being put on ventilators, so being intubated, breather tube down their throat, being bagged by the EMS response crew, and they're coming in, and ideally they eventually the body metabolizes this and they wake up and they're fine, but it's all about getting to these people.
Yes, certainly. And the key thing that you said was the decreased respiration. They're not breathing. A lot of times, I think we as clinicians, maybe pre-hospital providers as well, want to give naloxone or Narcan, which is the reversal agent. And ideally, you would see the patient wake up and start breathing. But, they could have something else intoxicating them on board. They could have bleeding in their brain. There's a whole variety of reasons that they might not wake up, but you're still doing the right thing by focusing on their breathing.
Yeah, and I think people also get misconstrued because I think, like pre-hospital, let's say, police often are the first team to interact with a 911 call like this, right?
Yep.
So now they also carry Narcan, and they'll call, the EMS crew and they'll say, hey, he's unresponsive. I'm giving Narcan, come over. And then EMS crew comes in and they say, okay, how much did you give? Oh, I gave 2 sprays, like 1 in each nostril kind of thing. They're not waking up. Okay, great. So what are we doing now? Okay, well, I'm going to give more Narcan. I'm going to give more
Mm.
Narcan. And now all of a sudden, it goes from 1 to 2 to 5 to 8 milligrams of Narcan. They're not waking up. It's like, we got to figure this out here. It may be something else, or it could be, yeah, we have a stroke now or something to that effect.
Exactly. My kind of rule of thumb is once you get to about 8 to 10 milligrams of the nasal spray, if it's not working, it's not an opioid.
Yeah, take a step back and figure this out here. Now, so the most common opiate that everybody kind of knows about is heroin. Heroin overdoses, things like that. But we're seeing a lot of other stuff in the community right now, right? Can you talk about that?
Yeah, of course. And I think the first thing probably to say about heroin is since about 2013 or so, there's been, much fewer or much less actual heroin in the heroin people are buying. Over time, what is called heroin, in quotes, for those just listening, has actually become more and more of just fentanyl as well as analogs of fentanyl. So there's, many different modifications that drug dealers and producers can make to try to skirt drug control laws. So it's a lot of fentanyl in the heroin. And now more recently, we're also seeing other types of sedatives that are not even opioids mixed into.
Yeah, I mean, I'm seeing like veterinary drugs sneaking in here, and the issue with these is obviously we don't have an antidote for them. At least to my knowledge, we don't have an antidote.
Yeah, I guess it depends on how we're defining antidote. There is not a
Okay.
reversal. Yeah, there's not a reversal agent in terms of the management or what they need, which is not exactly an antidote, but they just need good supportive care. A lot of ER doctors will joke that toxicology is just recommending benzos and supportive care, which
That's
half
how I
of the
get through
time
my
is true.
day.
Exactly. It's a good tenant. But yeah, you're correct. There is no kind of reversal agent that acts like naloxone. So the two big veterinary sedatives that we've seen are xylazine and then medetomidine, and these are both tranquilizers for.
Yeah, and medetomidine to me is a little bit scarier from an emergency medicine perspective because I'm seeing these patients coming in hypotensive. I mean, their blood pressure is like 70 over 30. Their heart rates, I've seen normal heart rates of like 70. I've seen heart rates of like 20.
Mm-hmm,
And I'm looking at this and going, okay, give Narcan. And they're waking up. They're literally looking at my face and going, "What are you doing to me, bro?" And I'm like, I'm trying to save your life, but clearly I don't know if I'm helping because your heart rate is still 20 and your blood pressure is still 70 over 30 right now."
mm-hmm. Yeah,
It's-
no, it's very scary. Xylazine, I feel like had less of a bit of less hemodynamic effects, and at the end of the day, we're just kind of guessing based on trends. Like we've seen a decline now in xylazine and drug samples that are analyzed and an increase in medetomidine, so we can kind of surmise that that's what they might have in front of you. But there's a history of all sorts of adulterants like malaria drugs like quinine.
Yeah.
Occasionally diabetes drugs will pop up, and some of these drugs, and patients can
I
have like
remember that.
hypoglycemia.
Yeah, I remember there's a rash of those years ago of like patients coming in that persistently, like you can't get their blood sugar up. You had to put them on glucose strips.
Mm-hmm.
I'd
And I
forgotten about that.
no idea what the rationale on the drug dealer's side for that. Like maybe it tastes bitter, or you're making someone altered from hypoglycemia, which seems bad. But
It seems counterintuitive. I mean, you want to increase your sales, but killing your clientele probably isn't the way to do it here.
yep.
Now, I know that there's also a thought process that the drug dealer is going to put something into their product, cut it, and so a little bit, terminology and lingo. When we're talking about cutting heroin, we don't mean physically cutting it, right? But there's ways to increase the amount of a drug that is currently available to you. If you have 2 grams of heroin, but you have a bunch of buyers, so you need 8 grams of heroin, you basically dilute it. And then you're,
Mm-hmm.
you're quote unquote cutting it with other these chemicals. So the fact you can cut it with medetomidine means that you can increase your supply and potentially increase the potency. And people go, "Oh yeah, this guy gets a really good high," but
Exactly.
you're killing your clientele too.
Yeah.
So
And you can imagine the having full disclosure, not a drug dealer or having seen a drug dealer's operation.
mhm.
But I presume it's not, the most scientific or, rigorous, regulated environment. And just, we're talking about minuscule amounts, physical amounts of a drug to actually get you high. How do you,
Mhm.
you know, equally distribute that across that 8 grams that you're trying to make and then divvy up into smaller bags?
Right. I mean, look, we've all seen Breaking Bad to some degree, I imagine, like with meth and, the blue meth and all that. But so let's talk about fentanyl now being mixed in with the heroin because if you get a patient who comes in who snorted or injected or, whatever to their heroin and there's fentanyl component in there, Narcan still works for fentanyl.
Correct. Absolutely works for. for fentanyl.
So basically, we're just, like, what do you do? We're just giving more at this point?
Yeah, it kind of depends. How much naloxone or Narcan to give is, really a kind of a bedside call. You see how they're responding after you give a dose. And then in terms of, the amount that's needed, theoretically you shouldn't need more. Potentially you could need more for one of the more potent fentanyls like carfentanil, which unfortunately we see, now and again. But regardless of if it's heroin or fentanyl, naloxone should.
Now, do you see, do you have any data on the current regions that we're seeing some of these overdoses? So, like, we both work in the Northeast, East Coast area. Is there are you up to date on current trends like the West Coast, Central the US, Southeastern, whatever? I don't know if you have any of that data offhand.
Yeah, definitely not numbers, and I obviously have more experience here in the kind of Northeast corridor. The opioid epidemic really is, affected all parts of the country. There's not really any area that's been spared. From speaking with other toxicologists that practice in the West Coast, like kind of Arizona out to California, stimulants like methamphetamine, I think, are a little bit more
Hmm.
common out
Hmm.
there. And unfortunately, starting to see a lot of kind of mixed overdoses where, individuals are using both methamphetamine with fentanyl. And maybe that's intentional, but in some cases, we also get reports of contamination of other drugs with.
Oh, you mean the stuff isn't USDA approved and FDA regulated? That's surprising to me.
Yeah, believe it or not.
So, okay, we have a patient who comes in now on methamphetamine cut with fentanyl or vice versa, like whatever, heroin, fentanyl cut with methamphetamine. But methamphetamine makes you hyper alert and aware. So, what are these patients looking like at this point clinically?
Yeah, it's a great question. And it kind of changes throughout the course of their ED stay. The last patient I saw like this, the had a bit more of an opioid presentation, was a little bit more sedate, definitely had some respiratory depression. But then when they got naloxone, they didn't wake up to be a normal person. They kind of woke up and were hyper agitated, you
Hmm.
know, very fast heart rate, kind of getting up, walking around, which is what you would expect from, more of a pure stimulant side.
And it's interesting because you probably treated them with a benzo, like something like a, Versed or something like that. So, which is, like you just woke the patient up. They're half asleep, not breathing. And now, okay, I'm going to give you something to calm down now. It's like, what are we doing right now?
Yeah, yeah, exactly. It can be very, very difficult to manage. Patients can tolerate a little bit of decreased respiratory drive, decreased ventilation, and those patients you want to think critically about, when is the point when I actually need to administer the Narcan.
Yeah, probably when they're stripping their clothes off in front of children and grandmas. That's probably
Yeah,
when we
that's
need to do something. So here's a question then. This obviously, we're talking about ER specific patients, right? What's the judgment call for pre hospital EMS providers? Can they make a judgment call? Or is it just, do what you can, strap them down and roll them in?
yeah. You mean for the more for an agitated patient or a
Yeah, like, it's
kind of
like, let's
overdose?
say they get a call, the suspected overdose, and they get there and, they're drowsy, so they give them Narcan, right? They wake up, but now they're doing exactly what you said. They're, like, agitated, they're walking around, heart rate's like, 160. Do they now give the benzo if they're allowable, or are they strapping them down, or are you now concerned that there could be something else metabolic underlying these cases? Is it a methamphetamine or something else?
Yeah, that last point is very critical. It's incredibly hard to tell just in the pre-hospital setting what all is going on. If the patient is very hyperactive, but their mental status is, pretty clear, they're able to tell you what they took that maybe can push you in one way or the other, whatever it takes for them to be able to safely transport the patient as well as, protecting themselves while transporting the patient to care is ideal. Generally, I think medications are better to control a situation rather than going right to restraints. A patient who has some physical restraints, there's a lot of risk associated with that.
Yeah, we talk about I actually spoke to a reporter a couple years ago about agitated or excited delirium.
Hmm.
And that was, a hot button topic back in 2020, 2021. The idea that, police were restraining people who may have had some kind of drug injection or maybe having a medical episode. And suddenly now they're in restraints, they're not moving, and they now can't breathe,
Hmm.
and they're dying. What is the answer to this? Well, the answer is you get EMS involved and you have them at least monitor the patient. Now, if you can't, you need vital signs, you need oxygen, things like that to figure out, is this what's going on here?
Exactly. As much as I think you or I would feel a little bit limited in what's available in an ambulance. Our EMS colleagues can really accomplish a lot with their monitoring equipment. They've got several medications available to help them. Definitely a good place for them to be involved.
What's your thought on ketamine for something like this? I've heard of, mixed research and data says, hey, don't give ketamine to patients who may be having psychiatric issues or on psychiatric medications. But then you get the patient that's, agitated like this for whatever reason, and maybe they have something in their system. Is a ketamine going to make it worse? Is it going to at least control them? What do you think?
Yeah, ketamine can be a good option. It's, as I'm sure you've experienced, a little hard to predict how an individual patient might respond to ketamine. So
Some are fighting dragons, man. It's pretty impressive.
exactly. So, I think there's probably a trend or a reason that benzos are always a toxicologist's best friends. I, never hesitate to go with a little bit of Versed if I think that a ketamine might not be a good choice for that patient. Someone whose blood pressure is already, very high, is someone I would maybe also consider not giving it to. But, if that's all you have and it's what's more likely to keep the patient and the other healthcare personnel safe, then it's reasonable to try.
So I want to switch gears. We've talked about, obviously opioids. We're throwing ketamine out there. We're throwing fentanyl. And I think it's important because the general public, if you're listening to this, you've heard ketamine, you've heard fentanyl being used in very negative connotation times. Fentanyl overdoses, ketamine overdoses. I think Matthew Perry was the one who was he taking ketamine and then he ended up drowning in his hot tub. But understand that these are, good medications gotten illicitly. And I don't know if you agree with this. One of the things I've heard toxicologists say is it's the dose that matters. Like everything is toxic depending on the dose here.
Yeah, exactly. One of the key tenets is that the dose makes the poison. Anything can be, water, if you drink enough of it, can be harmful. So really anything can be. It's just the amount and, is the correct person receiving the correct medication or agent at the correct time. And yeah, I think that there's a lot of kind of fear and anxiety about these things. I know when I mention to patients in the emergency department that we're going to give them some fentanyl or give them some ketamine, it's not uncommon for folks to be like, you're doing what? Like,
What
hold
now?
on, pump the brakes. But yeah, I mean, both of these were, really developed for legitimate medical uses.
And, somebody who comes in now, our EMS providers pre-hospital are giving fentanyl for pain control, and it's usually in the setting of trauma, right? Like you have an obvious broken bone, you're bleeding out, gun it, whatever the case is. And they're like, hey, I need orders for fentanyl. I'm like, yeah, cool. Have fun with it. But, understand that we're giving these doses in micrograms, like really tiny amounts here. And like,
Mhm.
my common go-to dose is like 50 micrograms of fentanyl, which is a hell of a lot lower than 1 gram. They snort like 2 grams of fentanyl. Or it's like, okay, yeah. But then we get into a situation where the misconceptions occur, and yeah, the patients are refusing these pain medications, these good medications out of fear, out of what they see in the news or whatever the case is. How do you approach that with them? What's usually like the starter? How do you get the conversation started?
Yeah, I've really moved to just kind of leading with a question and asking, like, what exactly is it that you're worried about with this medication? And I think a very common response will be, I don't want to become addicted to it. Like, I don't want to be affected like I hear people on the news being affected. And, at that point can explain that you're not likely to become addicted just from an isolated use of an appropriate or an appropriately dosed medication. Sometimes people will get to other personal experiences they've had with the drugs or with family members who have overdosed, but really trying to ask and understand what the hesitation is.
And you mentioned about, see on the news, and I remember seeing a lot of videos online, less recently, but definitely elsewhere about first responders reacting to exposure to fentanyl, and especially fentanyl in its powdered form, heroin, whatever the case is. And then but they don't present like a typical overdose would. So, we go back to the toxidrome and, certain, like these drugs have a clear, defined clinical toxidrome, but they're not responding in that way. The officer, whoever it is, handling the suspect, all of a sudden gets powder on their hands or whatever, and all of a sudden they're like passing out, they're having like, seizure-like activity or something like that. That's not
Mhm.
typical. Like, what's going on there?
Yeah, correct. These videos do pop up now and again, and they're a little concerning, especially the way that they're reported in the news. Headlines can be a little bit misleading and even suggest that someone overdosed from seeing or touching or being around fentanyl, which just can't happen. In terms of what is actually going on, I think, these are people in very stressful situations. They're seeing something that they know to be very deadly. And, the kind of physical reactions that they're having are very real in the moment, but they're definitely not intoxication by a drug. You
So
can't inhale powdered fentanyl. It's just sitting there or absorb too much through your skin.
I was going to say, can it be absorbed in the skin? Powdered or liquid, actually, for that matter. Because I mean, our
Right.
nurses are handling liquid fentanyl, and sometimes it splashes or whatever. Like, is that something that they have to be aware of?
Yeah, so I mean, going back to, kind of basics for all of us, we should all be wearing appropriate PPE, gloves, things like that when doing patient care. So, if you're doing that and there is a spill, just removing those gloves, throwing them away. If anything got on your skin, just washing it with soap and water is more than sufficient. Fentanyl can be absorbed through the skin, but really only in unique circumstances. So fentanyl patches are used for chronic pain patients, kind of end of life care. And those are specially designed, kind of like occlusive patches to facilitate delivery through the skin. It's actually an interesting toxicology kind of conceptual study out there. Like, how long would it take for you to be in contact with those
Mm.
to become intoxicated? And you'd have to
Hmm.
basically cover your palms with them and leave them on for more than 10 minutes for you to even get an amount in your bloodstream that could potentially sedate you.
The patches or the powder or the liquid
Patches.
patches.
Yeah.
Interesting.
And then the powder itself is very, unlikely to dissolve. And, if any of this gets exposed to broken skin, it's a little more of a concern, but
Yeah,
really,
but
really not enough to make you sick.
yeah, I say in general, even like an inhalation, like we're talking people who snort like large quantities of, powdered fentanyl and powdered heroin that get a high. So here's a question for you, a pharmacological question, I don't know if you know about. Is snorting going to be the same efficacy as injecting? And my,
Mm.
my context to that is we as humans have something called a first pass metabolism. If you're a pharmacist, provider, whatever, you know about this, but the idea is you ingest something, you eat it, you swallow it, your body metabolizes it first through the liver. And then whatever is left over, now you have the remnant of the drug circulating and then it becomes affected. But obviously, if you're doing IV insertion, you kind of bypass all that stuff.
Mm-hmm.
So is it the same as snorting it?
Yeah, so snorting or kind of insufflating something through your nose also will avoid any first pass, kind of those first pass effects. And it's actually a very quick delivery mechanism. There is some thought that we're actually seeing less IV or kind of injection use of fentanyl these days compared to heroin, because fentanyl itself is what we call lipophilic, which basically just means that it can cross into fatty tissue very easily. So if you snort something, it can easily cross into your brain, and it turns out that's a very effective way, for people to get high using fentanyl.
It's interesting because in a way you can hide your use easier because you no longer have track marks going up your arms.
Uh-huh.
But obviously there's a risk to putting something like that, corrosive or anything into your nose. I mean, you have to be getting something going on in your nasal septum and inside your nose after that, right?
Yeah, I don't know if that's been looked at long term. It's definitely an issue with cocaine and stimulants that can cause vasoconstriction, narrowing of the blood vessels. But yeah, it certainly is kind of like caustic to the inside of your nose.
I remember in residency, I had a case where this patient came in with a bad nosebleed, and turns out they had no septum. The nasal septum,
Mhm.
the middle part of the nose there, it was completely chewed away. And it turns out it was from long term cocaine use from, I mean, decades ago at this point. But it was so eaten away that the nosebleed came from higher up in the nose. It was
Mm.
actually a part of the nasal artery. And I remember, so, we obviously have to put the whole, bilateral packing in and this and that, but there was nothing to actually push against. Like, there's no septum there. So
Uh,
this kept bleeding and bleeding. And I'm, throwing in these like, huge, we're talking like, yay big, what we
a
call
really
rhino
long line of
rockets.
rockets.
It was just not pushing against anything. You ideally kind of get all the way up there and push against the artery, but she's
Yeah.
still, this patient still had issues. This was one of my first ambulance rides down. I was at Metropolitan. I went down to Bellevue. And for those who don't know New York City, you go from, the Upper East Side down to basically, lower, I think it was in the 30s or something like that. I forget
Yeah,
where
yeah.
Bellevue is
High
at.
high 20s, low 30s, I think.
And the reason why I had to go was because Fire Department of New York doesn't really staff medics on its ambulances, at least regularly. So if there's any like a highly critical patient that you'd have to transport, you're either getting a nurse or you're getting a doc to go down there. And I drew the short straw. And so I went down there with this patient because I'm like, I don't know if this person is going to need to be intubated on the way
Hmm.
down there. If they're constantly bleeding, they're getting blood, choking on blood. I'm like, I have to intubate this person. I'm like, I don't
That's
wanna do that.
so
They're bleeding
scary.
like crazy.
That's so scary. Yeah.
Thankfully, it didn't happen. Actually, by the time we arrived at Bellevue, the bleeding stopped.
Classic.
So of
They're like,
course,
why
like,
did you
I
bring this
walk into the
patient here?
ER, I'm a resident, and all the other, like, ER residents are like, "The hell's this? Why is this even here?" I'm just like, "I promise it was really bad at one point."
I did a good job. This is a sign that
It's right.
what I did worked.
Well, they can be discharged, like, okay,
Oh yeah,
fine.
outpatient follow up.
So, okay. So the idea behind obviously incidental contact with these types of drugs, you're not really going to get sick from it. It's not going to be something that you're going to all of a sudden collapse and convulse over. I've heard talk that it's more or less a what we call a vasovagal etiology, where suddenly people, I think, like you kind of said, it's a high stress environment. They freak out a little bit, and I think something triggers in their brain, blood vessels dilate, they lose their blood pressure, and all of a sudden they're passing out.
Hmm.
But then they come back to within a couple of minutes without Narcan, without anything else. And it's like, no, if you really ingested this drug, you wouldn't be just waking up after, a minute or two. Like you would be out for the count.
Exactly. Yeah, and that gets back to the toxidromes that we were talking about before. So these patients, they don't have the opioid toxidrome there. If you look even while they're passed out or breathing in some of these videos, there's no respiratory depression. And in some cases, people are actually breathing quite fast, which is just not what an opioid would do.
Yeah. What message would you give to patients when you're talking about drugs like ketamine, drugs like fentanyl, even benzos? Because all of these are in the street. You talk about people who are highly dependent on benzos, for example, the Xanax. Like they're going through withdrawal from these drugs and there's concerns for seizures and this and that. But what message do you have if you're sending them home on like a Percocet or a Xanax, or you're doing outpatient ketamine infusions for psychiatric reasons, whatever? Like, what is the message as far as addiction goes, if you even know?
Yeah, it's a great question. The ketamine infusion one is a little, I think, harder to answer, and we're just starting to, I think, see and learn more about like ketamine abuse and misuse. In terms of opioids, medical community and these prescribed a ton of like Oxycontin and,
Mm,
really kind of spurred a lot of
yeah.
opioid use in patients, sending people with like month supplies of these things. There's been, I think, a lot of increased awareness on the part of the medical community in terms of limiting the amount of time someone actually needs an opioid, as well as actual restrictions and what we're able to prescribe. My message to patients if they're getting a short course of opioids would be to just follow the instructions on the pills. Use them only if you need them. All of these patients I will also send with Naloxone or Narcan. And I think, even if you're not someone who's prescribed an opioid, I think all of us should carry Naloxone or Narcan because it's not uncommon where you could come across someone who's opioid overdose just in your day-to-day life.
I have a question for you, and this is probably going to get me in trouble. Do you feel that sending somebody home with naloxone, with who's a known drug addict, for example, is enabling behavior?
Mm. That's an interesting question.
So for context, right? So there's a lot of social media stuff out there. And, as I start this podcast, I've become more, enmeshed in social media and different points of
Mhm.
view. And I don't recommend it. It's actually bad for your psyche. But I've seen comments from people, and usually it's individuals who hold a very specific viewpoint, an outlook on life, an outlook on these types of people, people who are addicted to drugs and opiates and things like that, well, you're just enabling them.
Mhm.
Well, it's just an excuse. A lot oftentimes they're missing the context
Mhm.
of their dependency, and, we're not psychiatrists. I'm not going to get into the reasons for dependency, right now. Obviously, it's a lot, but, my argument to them was, well, how are you going to fix somebody if they're dead? Like the idea behind this is, you want to eventually get them to a point where they can live and be productive, members of society. But in order to do that, you have to make sure they're alive.
I think that's a great response. And then, I think as a medical community, we're starting to recognize more that addiction, the correct term in this case would be like opioid use disorder, is a disease. It's like a relapsing and remitting illness. The number of people in the US that have it is similar to the number that has diabetes. And, people who need insulin for their diabetes, we don't call them insulin addicts, and you're just enabling their diabetes by treating them with insulin. So
Some people are. And some people are doing that in government agencies. I'm just going to leave it at that.
yeah, that'll be the next episode, a topic.
Yeah. That'll be yeah. We'll leave that for later.
But yeah, I think it's important when you interact with people who have these questions, and I also kind of ask people if they know anyone who has been affected by opioids, and more often than not, though, most people out there know someone who's overdosed or been impacted by an overdose in some way.
And I think it's important too that there has to be some level of compassion for these individuals. And I say that because one of my close colleagues has overcome opiate and drug dependence and is currently leading a very successful career as a physician. Actually, I know of two people, now that I think about it, two people who I know who overcame it to be physicians, and actually really effective physicians too. And I think that has to be kind of understated that, yes, there are people who are very far gone down the rabbit hole who will absolutely need intensive therapy. And the people that recover tend to have a lot of support around them. The people that don't, it's hit or miss. But this is not something that you can just decide to stop. I mean, an alcoholic can't just decide to stop drinking. They can, but then they're going to feel terrible. And there's I feel like no good amount of resources to help these people who do really want help and get better and stay healthy too. Because I think I like what your description is. It's a relapsing and remitting condition. It's like MS, it's a diabetes. Like this requires constant monitoring, constant care. And for these people, constant validation. It's easy to say, "Oh, you're fixed. Congratulations. See you. See you when we see you." And no.
Yeah, and the a key part of this for a lot of people will be what we call medication-assisted treatment, or MAT. There's other comments that you'll run into when someone might hear that someone's taking a drug or a medication like methadone or buprenorphine. Aren't you just replacing one addiction for another? And that kind of gets back to the what you were just saying about it being a chronic condition that needs managed.
Yeah, and I think first of all, people don't just kind of decide to become heroin addicts or alcoholics or something like that. There is something underlying all of this here. That there's are we replacing one drug for another? No, you're taking drugs to replace something in your life. I think that's really missing out here. But like I said, that's a discussion for a psychiatrist. And if you're interested, if you have a passing interest in psychiatry, you want to be on the show, please feel free to email me.
I'd be a great guest.
Zero, buddy. It's awesome. Dr. Christopher Counts, emergency medicine physician and a toxicologist. Again, smarter than me, more academic than me. Thanks for coming on to talk about this stuff. It was really good.
Thanks so much for having me. This was great.
My thanks again to Dr. Christopher Counts, board-certified EM physician and toxicologist, for coming on the show to discuss all things fentanyl overdose and addiction. Again, fentanyl by itself is not a terrible drug. It is a potent pain reliever that we give in the clinical setting to help with severe pain. However, we are seeing an increasing amount of fentanyl overdoses with deadly consequences. From the somnolent to the highly erratic, these drugs are mixed with other drugs too, to create a varying level of toxidrome that we as clinicians have a hard time treating in the acute care setting. One thing to keep in mind with fentanyl, though, is that it is not something that you can incidentally overdose from. The reaction videos that you see on the internet are actually just not true. Sometimes there are a vasovagal episode, a stress response, but they are not due to overdoses of the drug themselves. Obviously, use proper protection when handling any kind of chemical, especially if it's a narcotic or drug that you do not know the composition of. Protect yourself, but don't be afraid that you're going to incidentally inhale something and cause an overdose just by being in the general vicinity. If you or somebody you know has addiction problems, please seek support. There is help available to you. And unfortunately, there is no one-stop shop for a lot of these types of issues, but check with your local state precincts, hospitals. They all have resources to help you get the help and treatment that you need. And unless you have an allergy to fentanyl itself or other opiates or narcotics, please don't be alarmed when a doctor or a nurse or even EMS come at you with a dose of fentanyl to help alleviate your pain. That's it for this episode of the JAFERD Cast. Make good choices, and we'll see you next time.